Hello, I'm Tom DeBerardino from San Antonio, and today we're going to demonstrate the newest MPFL kit. And you've got the two drills for the initial drill holes, the 2.4 short and longer pin with laser marks for depth. And they also have a laser mark here if you want to do freehand, and a second laser mark here if you want to use these new small signature soft tissue guides that'll give you the correct amount of offset. We have parallel guides that have an option to be either 15, 17.5, or 20 millimeters apart from the mid-axial drill hole. So that one goes first, and then based on the size and shape of the patella, you can either use the parallel guide for a larger patella, or for a small circular patella, you've got this one that's tapered, so you're aiming toward the centroid of the patella and less chance of cutout for that more proximal screw and drill hole. We've got the cannulated 4.0 millimeter over drill, and that's freehand. No need to use the guide. It's got a laser mark to match the depth of your initial 2.4 hole. The newest addition to the set is really the benefit of the 3.9 SwiveLock BioComposite anchor. It's got the size of a small anchor but the strength of a larger anchor, all in two implants that secure the free ends of the looped gracilis allograft typically into the patella. We've got the same radiolucent guide to use fluoroscopically or with your imaging to guide you to get the perfect Schottles point for the insertion point of our medial femoral entry hole for our spade tip pin. That's a beef pin with a spade tip on it to allow for adequate opening of that far cortex to allow flipping of our ACL TightRope. So the TightRope has to be first over-reamed with a 6 millimeter low-profile reamer for the entry cortex to allow the graft to fit into the medial cortex of the drill hole. And you can go all the way across up to the far cortex if you are drilling before you know your final graft length, and that gives you the widest degree of flexibility to be able to support a larger length graft, because you're going to be fixed in the patella and then the looped end will be pulled into your medial cortex of your femur with that over drilling. Here's our TightRope. It comes for packaging purposes short, but most femurs are at least 6 inches across. So we like to lengthen this. So you just gently hold the implant and you pull whichever suture of the two sides. I do about 3 pulls initially to get enough length so that your graft doesn't hit the medial hole before your button deploys on the far cortex. So here we've lengthened both ends of the implant to allow for the expanse of the width of the thigh and the femur, so that our button flips on the far cortex before the graft goes into the medial opening. And that way we have the biggest amount of flexibility with adjusting where the implant is and to make sure the button seats against the far cortex. And remember, with this TightRope, we're going to leave the tightening sutures behind. They're not going to all be pulled across with the button. They're going to stay behind and be the tightening sutures on the entry medial side of the femur. And you're going to pull the graft in from medial, but it's going to pull it in toward the button laterally based. So here we have a left knee. So we've got our 2 to 3 centimeter incision just off the medial border of the patella. Remembering, we're going to push the patella into this incision, and then we've got a pre-marked 1 centimeter incision over the medial epicondyle, and that's about the appropriate spread. And you can feel it with flexion of the knee. You can feel the adductor tubercle and the medial epicondyle very easily in this specimen. So we're going to cut down and do our patella approach first through the skin and subcutaneous tissue. We don't use a tourniquet, so we'd use a bovie liberally. We're going to get down through the layers until we get down to the capsule. We're going to incise and retract. And then once we feel the patella, I'm actually with my right thumb having an assistant push the patella right into the wound, and it delivers it right out this little small wound, which is a nice pearl for a small incision. So we get down to the periosteum, and I'll use a bovie here and raise these flaps with a pickup. We'll get a small retractor in. So I'm already down on bone right here, but I'm above the capsule. So I'll retract this back as a thick flap. We're right at the equator for our first implant, and the second implant's going to go on this knee at about the 10 o'clock position right up here. Implant 1, implant 2. And I'll bovie down where my expected locations are, and that gives a good visual feedback to get the mark. So the capsule's still intact, deep in the wound, and we get a retractor up here, a little send maybe, and I'll put that in here. So we're pushing the patella, but we're pulling back the superior leaflet of the periosteum, and we're getting right down to bone. So here's our equator drill hole right here, and then the offset's going to be somewhere right about up here. We're going to use our soft tissue guide. So we're going to open that up just a little bit more on the top. And then we've got a good exposure of the medial side of the patella, down to but not through the capsule. So we take our first guide pin and load that up. So you can feel the top of the patella, and that gives you the angle. So we want to go in from 9 o'clock to 3 o'clock, basically at the equator of this patella, just above the capsule. And then the pitch is important because you can either have an Army-Navy under here to replicate in a thicker knee because of the soft tissue envelope, which angle you need to come in, anterior to posterior, and you want to be parallel to the anterior cortex so you don't breach it, and certainly don't want to breach the articular surface. So we drill this into the laser mark. We're doing it freehand. So that's right into that first laser mark. And now we'll use our small angled guide because this is a smaller patella. So we've got that right at the equator. And now we'll do a small offset because this actually is a smaller patella. And we bring our guide in, and it's right where we previously marked the blue mark up above. You can see that right up top. So that's going to replicate right where this sleeve is going to come in. And we can change the angle, but the rotation is fixed, so it's nice. So I'll hold one hand here with the second longer guide pin, which is nice because you won't hit the first one. So you're going to stop before you hit it. I'm going to pick the 15 millimeter offset, and again, it's angled, heading toward the centroid. And I can pick my spot with rotation for inferior or anterior base. I'm going to pick that spot there to be right along the equator above the capsule. I hold the guide down to bone, and I drill in, and that's nice. So now we pull that out, take our sleeve off. So now we want to over drill with our 4 millimeter cannulated reamer. So we'll do the long one first to get it out of the way. And again, there's a laser mark on the drill. Put some back pressure against the patella. Drill into the laser line, and then that's a stop. And then that all comes out together usually. And then we'll over drill our shorter pin at the equator, down to the laser line once again. And both come out. So now we'll often use a bovie to really own these holes. Here you can see them. They show up pretty nice on the video right here and there. So we've got good holes for our graft to go in. So while our graft is being made, the other key is to get down to the final layer outside the capsule with dissection scissors and pickups. So on this side, we'll go sub-Q with this retractor. And then I want to use this tissue here to get the plane just above the capsule, because that's going to help deliver the graft on the right layer, just outside the joint above the capsule right there. So we've got that ready to go. Right there, I can put my finger in there and not be in the joint. I'm right outside the capsule, so that's nice. Right in here, there's a nice plane. And that'll go right down to our epicondyle. So the next order of business, we're going to get our graft. We've tapered the edges. We say we want a gracilis usually. It's the right length, good tissue properties, small gauge. Tapered ends is the key. The tapered ends allow you to get the free ends into each of these patellar sockets with the delivery tip of the 3.9 SwiveLock anchor. So we've got a 3.9 anchor. We load the sutures that are pre-placed, and these are fiber loop sutures. This is a 2.0 fiber loop, and that's a smaller gauge but good strength. So we control the free ends, grab the graft, and I'll bring it right up to the tip like this. And usually we'll pre-mark with the marking pen how much of the graft we want in the knee. So I'll say we want about the length of the implant. So I'll mark that right there. We'll mark the other end in a second. So that gives us, and I'll put an incremental mark to make sure we're making headway so that the graft is actually deploying as the delivery tip of the 3.9 anchor goes in. So we want to get that seated first, and then we'll love tap this in with good counter pressure. You can see the graft going in nicely. And then we'll push and turn. Give it one more tap. You got to get that first thread engaged. This is good hard bone. And then we'll screw that in. Ah, nice bite on the bone is always a good feeling. You know it's down when it's visibly down. We'll give it one more turn. So we back the paddle up and we confirm that it's still one thread out, so we'll keep twisting in until that's absolutely flush. And now it's nice and flush. We uncleat our sutures, take the device out, usually with a mallet to love tap it out. We save these sutures to close up the soft tissue over the graft. So now we have to, before we put the second one in and load it, we have to put the tightrope mechanism on. This is one that we've lengthened. It comes short, but we have to lengthen by holding the button softly and lengthening the two limbs to be the width of your femur. Otherwise, you want that device to deploy on the lateral cortex before the graft gets pulled in immediately. That way you have the best amount and the highest level of control. So we feed our graft through the loop. Let that just hang down in an assistant's hand. So then with the second anchor, we repeat the steps we used and talked about with the first anchor and deploy the other free end of the loop, thus closing the loop with our tightrope pre-deployed on the graft. So now we have to pass this composite tightrope and looped graft above the capsule in this predefined layer, and I'll usually dissect it from anterior to posterior with scissors and get down to my area where I know, based on anatomy, my medial insertion site on the femur will be. And now we'll take the retractors out. We have our Arthrex radiolucent guide for establishing the perfect Schottle's point for the entry point between the adductor and the medial epicondyle. We know this is our MCL insertion site here. We can feel the bony prominence. We can lay this on to get it ballparked, lined up with our perceived posterior cortex of the femur, back cortex of the femur, and Blumenstadt's line. So we can put this on in place over our planned incision to make sure fluoroscopically with a rollover lateral view, we can check to see where that perfect point is. It's nice this new radiolucent guide has an enlarged hole to accommodate the widened end of the spade tip beef pin drill, so you can put this on first and actually use your beef pin to immediately drill right across if you like your point. So what we usually do first is make our incision. So we'll do that. And then we have better access to the soft tissue, and we've negated the soft tissue bridge that may make us roll off the bony anatomy, because it is a medial epicondyle. By definition, there's prominence, and you want to be down on bone. So that allows me to really get that tip and own my spot so I don't skive off when I'm putting the drill in. So I can either use a spinal needle if you're using a mini C-arm, because you can't come in like this with a big C-arm. You lose room. So we'll often mark it, hold it in place, and then pick our point, confirm with fluoroscopy. And then the secret here is to not drill straight across, because that's going to go maybe through the notch and, you know, injure your ACL socket and implant and graft. So you want to go proximal and more anterior. So it's two moves. Move your hand a little more distal, about 10 to 15 degrees, and drop your hand about 10 to 15 degrees so that you come up ideally right above the metaphyseal, diaphyseal junction, above the flare of the lateral condyle, above the IT band. We drill across, and you can use imaging here to check. We drill across, and we can let go here, and that can fall down. It's done its purpose. Now we want to feel laterally for that spade tip going across, and we can feel it below the skin. So then the idea is to not blow right through the skin. We'll make an actual nick with an 11 blade, and then the spade tip comes out. We can feed it across all the way till where the trail end is just sticking out of the skin. So now we'll take our scissors and then a curved Kelly to dissect from this point up to our starting point. So we've already started from here down. Now we're going to meet up with these two incisions. We're going to come out in that same plane. I'm going to widen the path. And then I'll take a curved Kelly or a curved clamp of any type, walk up that same pathway, and then I can either use a passing suture or just pass all the sutures en bloc. As long as I leave enough slack, I can pull that down. There's the button out, so that's the leader. I milk out the remaining free ends of the suture. The safety stitches from the anchors are staying up above for the soft tissue closure. And I gently pull that graft down. I can see here that both limbs are tight. We've got our loop end down here, and there's equal tension on both of the graft plugs and graft limbs at the top. And I can feel the patella move over. So we've passed our graft. We have good control of it. We use it as a skin retractor now, a gentle soft tissue retractor. We can see our low profile 6mm reamer come in from medial to lateral. And you need to drill in at least the amount plus 10 of the residual looped graft. So we're going to go as far over to the lateral cortex to give you as much leeway as possible. As long as you don't breach the lateral cortex, you're fine. So we've gone in about 40 there. We pull that out. We clear off some of the debris because we want to really be able to get into that opening with our graft. And then we just use the stiffened ends of these passing sutures only. The tightening sutures stay behind. They go into the eyelet of the beef pin, get pulled across. Before the button goes in, I want to make sure I, as the surgeon, and it's a kind of a push me, pull you back and forth sign mechanism to get ready to deploy the button. And here's where we'll use PA imaging. We'll get a fluoroscan image coming over the top as we watch this button deploy, perhaps, especially in a thicker individual, because you don't want to pull it out past the IT band. There's no need to see the button. You can watch it kind of like a syndesmosis tightrope. You can watch it deploy past the lateral cortex and then flip. And here you want to see with back pressure on your loop with my left finger that it's up against the cortex. And I would get a fluoroscopic image now with a little bit of rotation of the femur to make sure it's laying down flat against the cortex, and maybe take a freer in here to free it up. If there's any tethering of the outer IT band in stouter soft tissue, you can get in here through this tiny incision and free it up. But if you move the knee and it moves freely, you know you're down on bone. And if it looks like it's on bone on imaging, you're on bone. So I'm pulling that back. So now the secret is to use this in the loop, because you want to direct this graft in. So I have an assistant pulling the tightening sutures, left, right, left, and I'm the loop, and I'm redirecting that force so that the graft is deploying straight into the hole. As the mouth goes in, I can release the tension a little bit. We keep tightening it down. There's still no real tension. We've got this loop, and I start to roll my hand to the thinner part. And then once it's pretty tight, resting tension, I can slip my device out and do the final tightening. But now we hold the knee in about 30 degrees of flexion is what most of us have agreed upon, so that you absolutely don't want to over tighten the patella. So I'll actually push the patella laterally, and I'm doing this because I can feel the resistance. And as I'm tightening, I'm pulling the patella back into a reduced position and titrating my tightness, constantly rechecking. If it's a very complex case, I might put this arthroscope in the knee because I still have that on the table if I did arthroscopic surgery to start the case. And I'll check that station of the patella to make sure it's gone from lateral to central. Always checking my motion that I can easily get from 0 to just past 90. If you can do that, and you used all the parameters we talked about, putting the anchors in the right place on the patella and hitting the right spot for the insertion site with Schottle's point on the femur, you're going to be reasonably isometric so that the graft doesn't bind up the knee and you have good passive motion, because you're going to want the patient to be able to go 0 to 90 in that first post-operative check in the clinic so they don't get stiff, but their patella is stabilized. You can see and feel the tension through your proximal incision. And here we've got nice tension. We've got a patella that just has 1+ lateralization. I've done an EUA on the opposite knee and it's equal. So on this knee, I've matched the resilience and the tension in the medial patellofemoral ligament and the medial retinaculum. So when we're done, we're done. We can cut the sutures flush below the skin. We have 2 incisions to close. We'll use a free needle to close our little approach here, our soft tissue approach, side to side, and then a subcuticular closure for our portals, our incisions. We brace them in extension, and they're off to the races to start their rehabilitation program.